This is Dr. Bess Miller, and I'm here with Dr. Alan Greenberg. Today's date is July 26, 2017, and we are in Atlanta, Georgia at the Centers for Disease Control and Prevention. I am interviewing Dr. Greenberg as part of the Oral History Project, The Early Years of AIDS, CDC's Response to a Historic Epidemic. We are here to discuss your experience during the early years of CDC's work on what would become known as AIDS. Dr. Greenberg, do I have your permission to interview you and to record this interview?
Yes, absolutely.
Alan, you have been a global leader in clinical, epidemiologic, and laboratory research, as well as program implementation and operations research in the field of HIV/AIDS throughout your career. You have worked in many other fields, including malaria, tuberculosis, and sexually transmitted diseases as well. You have also been a leader in training and education in operations research and public health practice, and are currently chair of the Department of Epidemiology and Biostatistics at the School of Public Health, George Washington University. For this oral history of AIDS at CDC, we are focusing on the early years, beginning in June 1981 with the publication of the first morbidity and mortality weekly reports on the 5 cases of pneumocystis carinii pneumonia among homosexual men. But the story of CDC's work on AIDS in Africa began several years later. You served in a critical leadership role in CDC's work on HIV in Africa as director of Project Retro-C, the AIDS project in Côte d'Ivoire, between 1993 and 1997. And we will put some emphasis on this period of your work as well during the interview. But let's begin with your background. Tell me about where you grew up, your early family life, and where you ended up going to college.
Thank you, Beth. Good morning. My family and I grew up with my parents in the Bronx, New York. And my parents were both school teachers and raised me with a strong sense of social justice. I went to high school at Bronx High School of Science, as did my wife. And the first experience I had with healthcare was during the Vietnam War, actually, where I co-founded and led an organization called the Bronx Science Volunteers at Veterans Hospital, where we recruited, I think, about 40 high school students who would go to the hospital once or twice a week and fulfill various voluntary purposes, from being candy stripers to feeding veterans who were quadriplegics to working in the laboratory to delivering lab results to doing whatever the hospital needed. And my own job was I taught table tennis, ping pong, to wheelchair patients and went with them to tournaments. So that was my first experience with health, and really, I think, led to me wanting to become a physician.
Where did you end up going to college?
I was fortunate to go to Amherst College in Massachusetts, and I was actually a pre-med English major. I did my dissertation in Shakespearean literature, so about fools and folly and in Renaissance literature. But I picked up on that theme of volunteer work, and I also, at VA hospitals, the VAs have been a big part of my life, and I was director of an organization called the Five College Valley. The 5 College Valley volunteers at the Northampton Psychiatric Facility, VA. And that was an incredible experience because we provided basically companionship to, at that point, it was the psychiatric hospitals were filled with schizophrenic patients and manic patients, and they were lonely, and we were able to provide assistance to them. So those were the roots of my medical interests.
You mentioned some things that influenced you to go into medical school. Were there others, family, other people that inspired you, or it sounds like it kind of came from within?
Yeah, I think it did. We didn't have any physicians in our family, so I was actually I could be wrong, but as far as I knew, the first physician, certainly in our immediate family. There were fewer options growing up in the Bronx. You know, right now, as I think our children are aware of so many different career options available to them, the internet, people either became accountants or, people who did well in school became accountants or lawyers or physicians or business people. That there wasn't the full, I had never heard of public health. There wasn't the full spectrum of choices. And if you were doing well in school, the sort of, I don't know, societal or familial expectation is that you'd go into one of these specialties. So, but it was really, I think it was my social justice sense during the Vietnam War that I was quite aware of the we lived near the Veterans Hospital on Kingsbridge Road, and I was able to get there by myself. And I think it was that notion of trying to help that took me into a medical setting, and then I watched the physicians and said, oh, I could be one of them. So I think that's how it started.
Where did you end up going to medical school?
I went to George Washington Medical School, where I now work. And it was a great honor to be accepted there. I got a great clinical education. And I went to medical school thinking I'd be a family practitioner and a community physician. But a couple of things happened along the way in medical school that changed my life. And
tell us about that.
Well, the first was during, I think, second year of medical school, we had a lecture on tropical diseases from I believe his name was Dr. Millar. He was a pathologist. And he was showing guys with mosquito netting and scooping up mosquitoes and traveling to foreign places. And I'd never really left the Northeast United States very frequently. So to me, it was all exotic and fascinating. At the end of his lecture, he said, the diseases I just spoke about are responsible for more mortality in the world every year than all the other diseases you'll learn about in the 4 years of med school. I'm not sure if that was actually true, but it was an inspirational comment. It might have been true. And he said, so for those of you but they only give me 1 hour in the syllabus. And he said, so for those of you who are interested in learning more, please come up to me after class. So my roommate and I were young and brave, and we sort of wandered up, and he had small scholarships to send medical students to Africa, and that's what changed my life. And so it took a couple of years, but as a fourth-year medical student, I had the opportunity to work I spoke French from high school, and so they assigned me to a Swiss missionary hospital in Côte d'Ivoire, in Ivory Coast, where I also wound up circling back to many years later in a small town called Dabou, which was about an hour or two outside of the capital of Abidjan. And I did a sub-internship as a fourth-year medical student there for 2 months. I had a little house and cooked for myself, and every day would go to clinic, largely doing outpatient. And I'd sometimes follow the doctors around on rounds in the evening, but mostly I was doing outpatient medicine and general medicine. And there was, every day there would be lines of people. We'd start clinic at 7:30 in the morning, and by that time people would come from all the neighboring villages just with their own ailments, a wide range of tropical diseases, and then many, many, many mothers with kids with fevers. And so, I mean, the line stretched, I'd say blocks, but there weren't blocks, but just seemed endless. And we'd work all day, and child after child had a fever, and many of them had malaria, and we were treating them for malaria and treating with chloroquine and treating with chloroquine. And I remember having a thought which really changed my perspectives when I one day thought, well, I wonder what's at the back of this line. Like, why are all these kids getting malaria as opposed to just endlessly treating? And it was that moment that I really had my epiphany that maybe getting into preventive medicine was something I'd like to do as well. And so that was a very important moment in my life. The second thing that happened was other sub-internships. My family, as I said, was from New York, and we were in Washington, where I also wound up circling back to live as an adult now. But we had the opportunity to do sub-internships at other hospitals and to sort of, see where we might want to do our internship and residency. So I did 2 in New York, one at Lenox Hill Hospital and one at St. Vincent's Hospital in the Village. And St. Vincent's was the community hospital for Greenwich Village. And, to be honest, I liked jazz, and I always thought growing up in New York, the Village was a really cool place to live and seemed very progressive. And St. Vincent's, was definitely a place that tried to work closely with the community. So I did my sub-internship there, and I do remember that was spring of 1982. I do remember working in the intensive care unit, and there was a patient who presented with pneumocystis pneumonia, but did not have cancer. And so most people with pneumocystis at that point were immunosuppressed because of malignancies. And I remember the attendings being a little perplexed and thinking, why would this happen? And wondering whether or not it was related, because actually I can't remember the risk factor of that particular patient, but it was my first inkling that there was something going on. And then indeed I love St. Vincent's. I love the spirit of the place, so it was my first choice, and I matched, much like the EIS match. I matched to St. Vincent's and moved to Greenwich Village in the summer of 1982.
Tell us more. I mean, that was the absolute epicenter of the HIV-infected world as we know it now at that time. So during your training, your internship and residency, you must have seen a lot of these patients. And can you tell us a little bit about that? What was the clinical care like? What was your reaction to all the illness? You were there. Yeah,
it was ground zero, that's for sure. I guess like many young physicians who were practicing in the early 80s in San Francisco, New York, and LA, we were there at the beginning. And as I said, I went in wanting to become a family practitioner or a general community doc, and walked smack into the beginning of the HIV epidemic. And it was very trying. It was and very inspirational at the same time. The number of young men, gay men, who walked into the emergency room with either Kaposi's or pneumocystis was extraordinary. I mean, day after day after day, morning report, people would throw up the chest x-rays with pneumocystis and type picture, and the amount we could do for them was limited. There were aerosolized pentamidine and IV Bactrim, I recall. I hope I'm not getting my drugs mixed up many decades later. But so there was treatment, but the underlying cause wasn't even known. I think at that point it was called GRID, gay-related immune deficiency. It was the pre-HIV days. And, these patients got, many of them very, very sick, and many of them died. And on the clinical end, it was very frustrating being a young physician and taking care of, it's like a battlefield. There's so many young people who are passing away before their time. And although we struggled mightily, it was, there were no antiretrovirals. We didn't even know, I think at that point it was a virus. And so it was a very, very challenging time. A lot of the patients were passing, a lot of the staff, because we were living in Greenwich Village, so had risk factors as well, and some of them were getting sick. No one knew if it could be passed, parentally. I mean, and I remember we saw our first hemophiliac with HIV. I remember that patient very well. And there was also, not only was it emotionally trying because of the frustration about not being able to help more people, but it was very, there was a fear among the house staff and among the nursing staff and the technician staff that, we could get infected too. And, and that was realistic. I mean, at that point, I don't think the same kinds of barrier protections were in place. We were intubating people, putting A-lines in. No one was wearing gloves. We were constantly exposed to, bodily fluids from all sorts of patients. And, I remember actually telling my parents one day going home and saying, I didn't predict this, but I'm in it, and I'm trying to be the best physician I can, but there's a chance we could all get it too, and I just wanted you to know that. You told me I get emotional telling your mother that, Wow. But, so there was a bit of, I won't talk about myself, but there was a bit of courage that I really admired in the, frontline nurses and house staff and social workers and, respiratory therapists who were taking care of those. It was lots of camaraderie.
Do you remember having any experience with CDC at that time? Did people look to CDC or even the New York City Department of Health for any kind of guidance at that early stage?
That's a great question. I honestly can't remember. CDC will become part of the story very soon, But I honestly can't remember those early days. We were, to be honest, you were working, at that point, call was much more frequent. We were on call, there were, I forget her name, Lizzie, there weren't those laws in place yet. And so when the months we were in the intensive care unit in the emergency room, we were on every other other night, and when you're on the wards, you're on every third night. So to be honest, I wasn't really paying attention to the larger world. I was just trying to take care of my patients and trying to
stay alive
and get some sleep. But on the other hand, so I think just to sum that section up before we transition to CDC, I think that if there was a positive aspect to that, was watching the courage not only of the house staff but also of the people we were taking care of. I mean, it was horrible to be, in your young 20s and have this sort of diagnosis given to you, and to feel that ill. And so many of them were so courageous. And I remember quite a number of them looking at me and saying to the effect of, "Doc, you may not be able to help me, but help other people." I heard that frequently. The altruism, the courage. And I think it was that where I decided to devote my life to HIV prevention.
What led you to CDC then? Was it that very thing?
Well, inspired by the epidemic as I was, I was going to go do my infectious disease fellowship, as many of my peers in the profession did, and two things happened. I think one was that I went to the head of infectious diseases. His name was Jay Kislak. There were two infectious disease doctors we worked closely with taking care of all the HIV patients. And his name was Dr. Jay Kislak. He was the senior physician. And I went and I said, "Would you give me a recommendation for an ID fellowship?" And he said, "Of course." He said, "But weren't you the guy who went to Africa during medical school?" And I said, "Yeah." And he said, "I have another idea for you." He said, "Have you ever heard of the Epidemic Intelligence Service?" I said, "No." He said, "Have you ever heard of CDC?" And I said, "Kinda." And he said, "Well, how? There's this program where they train disease detectives, and you could get involved in a wider scale. And I think with your language skills and with your history of having been comfortable in the developing world before, this might be something you should consider." And so that was one, and I'll circle back to that. The second thing that happened was, and I was contemplating it. I was actually, I think, named one of the chief residents for the following year, and that was going to be my path to do chief residency and then apply for ID fellowship. So he said that, and then a couple of weeks later, I was sitting in morning report with the other residents, eating a cream cheese on a bagel and drinking my coffee from the Greek diner, and I was reading the New York Times. And I should find this article, but it was an article in the New York Times where they announced that, I was vaguely aware that HIV had hit Africa, and that CDC set up a field station in Central Africa in collaboration with the now Congo, but at that time Zairian Ministry of Health and the Belgians. And it was in a Francophone country, and their idea was to, be first responders to the HIV epidemic emerging in Africa. And I remember thinking, that's it. That's what I want to do. It clicked. That was the moment. And
How exciting.
And so then I called CDC, and I made my appointment for interview. I applied and was asked to come down for an interview. And when I came, I met all the incredible disease detectives. I think Gail Bolin interviewed me, and I was people were traveling all over the world doing yellow fever and GI outbreaks, and I was just smitten. I called my mother. I said, "I found my people. I found my people." And I'm sure you probably had that kind of experience too, but it was a real epiphany moment. I went back to St. Vincent's, and I was supposed to be chief resident. I had to tell the chief of medicine that I was going to pass it up and do EIS, because at that point I just found out I had gotten into the program. And I was a pretty good doc and very committed physician, and they were concerned that I was throwing away my medical career, or that they were being honest, and in some sense it was true. I did a lot less clinical medicine. I did a lot of clinical medicine, but not as much as I would have. And so they were just as mentors saying, "Are you sure you want to do this? Because you'd be a great ID physician as well." And I said, "I'm sure." And so I'm not sure I had their total blessing, but I then packed up my bags and moved to Atlanta. So,
Tell us about your EIS training a little bit. Where were you assigned, and did you begin working on AIDS early on?
Well, not surprisingly, I wanted to work in AIDS, and so I came down and sorry about my voice. They still have the famous match, and so you have that. Is that still, yeah? And so you go through the match process, and I went to see Jim Curran, who was the head of the HIV program, and I'm not sure I met Harold Jaffe at that point, but I definitely met Jim Curran, and I said, you know, coming from St. Vincent's, I've been doing HIV care for 3 years. I probably didn't use HIV at that point, but and I said, but I want to work in AIDS, and he said, well, they just started the San Francisco cohort, men's cohort, and they needed someone to work on that, and I said, well, I want to work. I brought up my New York Times article. I want to work at the field station that you're starting, that Jonathan Mann is starting in Africa. And he said, well, that's not what we need. So I said, well, I don't remember exactly the moment, but I thought to myself, well, then I should work in tropical diseases because at least that'll get me to Africa. And so I then met Kent Campbell, who was the chief of the malaria branch, and he was one of these real globetrotter figures, tropical diseases, sort of like hearkening the people in the lecture that I had in medical school, you know, and I said, I want to be like this guy. And so I was successful. I was fortunate. Malaria was my first choice, and I guess we matched there. And I became where I did EIS, where I spent 3 years. And so, I don't know where you're going next, but it wasn't too many weeks later that my HIV saga began. So,
tell us about that. Tell us about your HIV saga. And I know that you got the opportunity to work in Zaire on Projet during your EIS. But
well, a couple of things happened. The first thing was that we got a lot of phone calls in the malaria branch from clinicians with different cases of malaria who needed advice about how to treat it, because not everyone was obviously sees cases of malaria that frequently in the U.S. There wasn't the internet to look everything up, so we'd be called upon for consultations. And I was able to get involved with several cases of, and this is relevant, of chloroquine-resistant malaria, where people weren't responding to the usual treatment, and we had to help guide their treatment with other medications. And so that was an important building block, because I was sort of became, thanks to Kent, very familiar with drug resistance as it was emerged. It had already been prevalent in, my recollection was in Southeast Asia and in East Africa, but it hadn't spread to Central and West Africa. And I think some of my early publications, we were documenting some of the first cases in travelers, not the first, but some of the first cases of documented chloroquine resistance in travelers coming back from West Africa. And so the other thing is I was working with Kirk Miller, who was the EIS officer a year before me, and this is, again, very relevant. CDC, the treatment for severe malaria was IV quinine, but that wasn't available at all sites in the United States, so the quarantine stations had them. And we literally would have to, release the quinine from the different chloroquine stations and sometimes have it flown to these little towns or wherever the doctor was treating malaria in the United States. And it was a great responsibility because it was time sensitive. We had to get the drugs there on time. And so Kirk came up with the idea that IV quinidine, which was available for cardiac purposes, was also effective for HIV, and hospitals had it. And so he wrote a protocol whereby instead of recommending IV quinine, my recollection is, and there's articles about this, but it wasn't my study, but that IV quinidine was recommended. So we would go and fly to cases where sometimes we would go and help and actually go and document the treatment. And so there was a call from, I think I had been at CDC, they told you to keep your bags packed. And a couple of weeks after I started my EIS rotation, we got a call from Wilford Hall Air Force, the medical base there in San Antonio, Texas. And so we were also doing a protocol with exchange transfusions to try to save people's lives. And someone had a severe parasitemia. It was a soldier from overseas. And so we went and treated him, and the doctors there saved his life. But the good thing was he survived, but then we got a call a couple of weeks later that they figured out he was HTLV3 positive. And so that's when the question began, well, did he get such severe malaria because he was HIV infected? And that was the first part of the story.
So you get this assignment to go to Zaire, Projet SIDA, during your EIS experience, which is like amazing. Who gets to do that? Tell us about that.
Well, what happened was we had this case of the soldier in our heads about this possible association between HIV and malaria, and things were happening very quickly. And Jonathan Mann in Kinshasa published an article in which he was looking at the prevalence of HIV in children. He actually published 2 sentinel articles. And my recollection is the background seroprevalence in healthy children was about 1%. But among hospitalized children with malaria, it was 6 or 7%. And so that was the second piece of evidence that we thought, oh, maybe there really is something going on here. And so, I remember that we had this map of where malaria was in Africa and where HIV was emerging, and they were overlapping. And we thought, wow, if these 2 diseases collide, this could be a major issue. And so we went to Jim Curran. So Kent and I actually came down here to Clifton Road and met with Jim Curran and said, we have an idea. We'd like to work in Kinshasa, which was, my hope. And Jim remembered that and worked with Jonathan Mann to do studies to see what the relationships were between HIV and malaria. And so he called John, and John said yes. And it took a couple of months to get approval from the Zairean Ministry of Health. But, it was a public health emergency at that point. It was definitely,
Could you believe your good fortune in these difficult circumstances?
Well, was that chance favors the prepared? Because I spoke French, and because I had worked in French West Africa before, and because I knew clinically HIV, there weren't that many people, certainly at CDC at that point, who had that spectrum. So I was fortunate, but what was really fortunate was that John Mann and Jim Curran and Ken Campbell had the vision to support me, and I went with my mentor Phuc Nguyen Dinh, who was a parasitologist, who was an expert field worker, had worked all over Central Africa and Haiti, and he went with me on my first outbreak investigation to Zaire.
So at that point, the virus had been identified by the time you got to Zaire.
Yes.
Do you remember some of the projects you worked on during that time?
Sure. I mean, we had written a protocol to basically go to the emergency room of what was called Mama Hospital, which was a large public hospital in Kinshasa, where Projet SIDA was based. And Projet SIDA was, again, put together by NIH, Tom Quinn and Skip Francis, the Belgians, Peter Piot, Marie Laga, and Bob Koblender's, and the U.S. government and CDC, which was Jim Curran and John Mann was the director. And together they formed the project. And so I literally flew in the middle of the night with Phuc, and I remember there were soldiers at the airport, and when I saw John Mann show up on the tarmac, I was like, oh, thank God, And so John took me in his car, and we drove to Mamiemo, and it was the middle of the night, and he took me to the pediatric ward, which was full of children getting infusions, and he said, laying on the floor with their mothers on blankets, and he said, this is the problem you're here to address. Most of the children here have malaria and HIV, I remember it was a dark room, poorly lit, and there were mosquitoes everywhere, and one of the issues was, were mosquitoes transmitting HIV? And I remember getting bit up. And I said, well, I certainly hope what we find is that they're not. Anyway, so we then launched into the key studies that I think defined my career. And do you want me to talk about those?
Well, tell us a little bit about Jonathan Mann. I'm jealous that you got a chance to work with him. He sort of has emerged as a larger-than-life figure in the world, and early AIDS and all the work he's done there and at WHO and afterwards, and sadly died in a plane crash in 1998. What was he like?
Jonathan Mann was was a great man, and it was indeed a privilege. I knew him well. I was at the project for I think I had 5 trips in 2.5 years, and each one was for a month or 2 or 3. And I worked with John every day and had the opportunity to watch him and learn from him. He was a visionary. He was prolific. He understood the importance of publishing. He was kind. He was a visionary. And I actually remember when he got the call from, I don't know if it was at that very moment, but I remember the day that he got the call asking him to go to Geneva and work on the global program on AIDS and to found and direct that. I remember he actually asked me, "Do you think this is a good idea?" I said, "John, if anyone could do this, you can," because it was quite, you know, these certain people who have that aura and that glow. And
what was the aura? Was he an extrovert? Was he outgoing? Was he quiet? What made people drawn to him?
Vision. He realized that the HIV epidemic was a crisis. He realized that we were at the very beginning of it and it was going to get worse. And he wanted to raise awareness so that the world would react, and you know, in very much a social justice perspective as well. And so, and also never underestimate, he set the standard for writing. I think one of the hallmarks of Project CETA was the enormous amount of productivity that came out from everyone who was, not everyone, but most people who were associated with that project. And so he used the published literature as a vehicle to get the message out about, you know, how severe a crisis this was. And so I think it was that combination of, and also, you know, I don't know if you ever heard him speak best, but this man could give a speech. I mean, you know, maybe not in the category of a Martin Luther King, but you know, he could get up at his talks at the international AIDS conferences would bring thousands of people, literally thousands of people, cheering and to tears. And he could, you know, you can read some of the texts of what he was saying. Those were events. I remember, you know, when John, there was a story a couple of years later. I was asked to speak speak at a symposium at one of the international AIDS conferences, and there was a room full of people, and we were getting ready to start. And then over the loudspeaker, they said, you know, John Mann is giving a special address in the main auditorium, and everyone left. And I said, "Well, this session's over. Might as well go listen to John." I mean, he was a rock star, and
wow.
And he was deeply respected. So it was real. He loved Toblerone. He always kept Toblerones in his office, and we circled back to him later when I actually got to work with him. He invited me years later when I left Côte d'Ivoire to work with him at the Harvard School of Public Health at the FXB Center he started, and I flew, when I was setting this up, I flew from Abidjan to Boston and spent the day with him at Cambridge, and he imparted many life lessons to me that day, and I was really looking forward to spending 2 years in Boston with him. And then a couple of days later, he took that. Actually, what happened was he then became the dean at I think Allegheny School of Public Health, and he actually had to tell me he was leaving Harvard, so I never got to work with him. But he came to visit Harvard, and we had lunch together in the School of Public Health cafeteria, and I think that was a couple of days before the Swiss air crash. But he was. You know, one of my, along with Fook and Jim Curran and Ken Campbell, one of the people who inspired me and was clearly one of my mentors scientifically, and would always sit down and go over my study design and results, and was interested and aware, despite all the million major things he was doing, he kept his eyes on the details. So it was a real privilege, and I considered that to be one of the good strokes of fortune in my career. So.
You talk about methodology and scientific rigor and writing, and your career has demonstrated how much you've done that and how much you've succeeded in that line. You want to mention a few of the projects that you were doing at that time in Zaire?
Sure. Our original study was, we went to the emergency room and hoped to reproduce John's results about because we were actually doing the blood smears ourselves and seeing if we can document the higher seroprevalence of pediatric malaria patients. And so we enrolled, I think it was a basic case control study, we enrolled, I forget the sample size, 150 kids with malaria and 150 kids without malaria, and we were doing all the parasite testing ourselves, the malaria smears, and going to the lab and separating the serum and doing the HTL3 testing, and the lab would then do those tests. And so we were very hands-on, and I was seeing all the patients. And then we got the results back. I can't remember time. It was probably several weeks, and we were working very quickly, night and day. And we hit our sample size and the results, and it was 1% in both populations. And so I remember calling Jim Kern and Ken Campbell on the phone and saying, I didn't reproduce the results. And they said, well, John Mann's, are you saying John Mann's wrong? I said, no, I'm not saying John Mann's wrong. I'm just an EIS officer. They said, well, keep working harder. This is an outbreak. This is an emergency. So we then figured, well, maybe we had some sort of selection bias in Fuch. And we took all comers in the emergency room. We rolled over 1,000 and did blood smears and HIV testing on them. And then once again, we didn't find an association. And then I had this moment which where I was seeing all the patients myself, and where I put two and two together, and there was one 6-year-old boy who had come in with his mom to the first study who was HIV negative. Then he came in a couple of days later and he was HIV positive. And we retested the specimens. I said, how could this have happened? And then I was going through his medical record, and I realized that in the emergency room he had gotten a blood transfusion that first visit, and then that maybe, and then he was sent home, and then came back and was captured in the second study's catchment, and then maybe it was blood transfusions. And I remember I have this realization in the middle of the night, and I woke Fuch up and I said, I think it's the blood transfusions, because John had published that blood transfusions were associated as well. And he said, but it couldn't be accounting for all this HIV. So we went back and did chart reviews in the emergency room and saw that a very high proportion, I forget the numbers, but of children with malaria were getting blood transfusions in the hospital. And what had happened was, our theory was that chloroquine resistance, circling back to that, had just hit Central Africa. So the mom's standard treatment was chloroquine. The kid would get a fever at home, they'd go to the pharmacy, they'd give chloroquine, and then they'd come in despite chloroquine with chloroquine-resistant malaria. And they thought they'd already treated, so by the time the kids came in, they were anemic. And so they had a fever, parasitemia, and anemia, and were appropriately getting transfusion. And we actually looked at the hematocrits, and they were getting appropriately transfused. And so, and then we did studies of the blood donors. Blood donors were either paid blood donors, who were professional blood donors, or family members. And it turned out their seroprevalence was, I think, about, I can't remember, but there was significant, I want to say 6%, but I have to read it, but there was a significant amount of HIV in the blood donor transfer, and no one was screening the blood. And so we then calculated how many transfusions at this one hospital alone could be accounting for it, and it was significant. I mean, it was, I think, 500 or 600 cases a year. And this was presumably going on in other institutions as well. And so we then went to the pediatric hospitalized patient and repeated some of John's studies, and indeed, and looking specifically at the role of blood transfusions, and found there was some children had gotten 1, 2, 3 or more blood transfusions, and there was a dose-response relationship between the number of transfusions people had gotten and the HIV seropositivity. And we actually were able to document the case. I think 10 or 11 of the HIV patients were malaria patients who had gotten transfused. And so
amazing. What was the response to that? And they weren't ready to do HIV testing of blood products, but how did the community respond immediately to this finding? Immediately,
I remember in the JAMA paper, there's actually a curve of the number of transfusions. I think they were transfusing with a hematocrit of 30 or below, and they immediately reduced that to like 20 or below. So there was a great drop off in the number of transfusions. And then this could be wrong, but my recollection is that Fuch went to WHO, and I can't remember, but certainly we came back with the results of CDC, and the blood screening, HIV screening, or HLV3 screening for blood units became a real priority pretty quickly.
Really?
I had the opportunity at the Third International AIDS Conference was in Washington, D.C. Right. I had an oral presentation, and it was my first major talk, and thousands of people sitting there. I had to go out and present this story, and I remember my knees were clanking together, and Dr. Kapita Bila, who was the head of pediatrics at Mamiemo, was the moderator of the session, and he said, "Courage, Alain, pour les enfants," courage, Alan, for the children, and so that was picked up.
That was a big, important meeting.
Yeah, that was picked up on NPR, and the word got out about the importance of blood transfusions, which John had already, documented, but the severity of it hadn't really. And so, that was the immediate public health link, that children with presumably resistant malaria, which we then documented, were coming in with fever and being treated with malaria, but leaving the institutions with HIV. So.
What an incredible AIS experience.
And the other, if I can just, if you don't want me to go on, but there was a whole other line of work in that John's successor was another great figure, Robin Ryder. And with Robin, I worked with Robin for the last year and a half or so, and Robin did I think to my knowledge, the first mother-child transmission study.
Yeah, we had the opportunity to interview Robin.
Oh, you did? And
yes.
So we did a malaria sub-study of that cohort, because he had a matched cohort of mothers with HIV positive and negative to follow and the children, and we were able to, every time those children got a fever, document that and do a malaria smear on them. So we were able to look at the incidence and response to treatment of and the severity of the parasitemia in children with HIV versus not. So that was an incredible experience working on that study, which again we'll circle back to. So.
Wow. Before we move on, I'd like your thoughts about the origin of AIDS, and what was the thinking at that time about the origin of AIDS being in Central Africa?
I remember a couple of stories. My recollection, and again we're going back 35 years, is that there were two Sentinel articles published, one by Peter Piat's group in 1984, documenting what they thought were the first cases of HIV in Central Africa, and then a second by, there was a group led by Joe McCormick, if I recall. So Joe McCormick went with Jim Kern and Tom Quinn to Kinshasa, and I don't know how, I wasn't there. I came along about a year later, but they were the ones who together decided to start Project Zeta, and then and hired John to run it, and then Skip Francis from NIH and Bob Kolbunders were assigned by Institute of Tropical Medicine in Belgium to be the first scientists there. In terms of origin of AIDS, while I was in EIS officer, the year after me came another one of my great mentors and friends, Dr. Kevin de Kock. And Kevin was in the viral special pathogens branch working with Joe McCormick, is my recollection. And Kevin published a very well-known New England Journal article where they went back to, I'm going to forget the name, Yambukru?
In rural Zaire.
In rural Zaire, where there had been an outbreak and specimens collected many decades ago, and they were able to look at the origins of HIV. So Kevin's paper was also one of those Sentinel papers.
Yeah, it was the Ebola outbreak in rural Zaire.
Right, it was
that had the blood samples. So
right,
yes.
so they went back, and Kevin went back, and I remember we presented back to back at the EIS conference my second year.
Yeah, so how exciting to have actually gone as an EIS officer to the site of it all. That's just amazing. It was the greatest privilege of my career. And then you moved on, a big drastic shift from Central Africa to the New York City Department of Health, Office of AIDS Surveillance. So at this point there were reported about over 82,000 AIDS cases in the U.S. and about 14,000 cases reported in New York City. This is before HIV test reporting, but AIDS, quote-unquote, disease reporting. What were your main emphases at that time? What did you get involved with in New York City? Well, the story was that I had been on the road for 3 years, back and forth. It was, trying to publish all these papers. And I missed home, and I missed my family. And I went to Jim Kern, and many times in my career, he had this pivotal influence on me. But he said, I said, I want to go home. I'll come back, but I want to go back to New York for a couple of years and be closer to my family. Do you know of any opportunities,
even outside of CDC, where I could work in public health in New York. And he said, well, it just so happens that yesterday he had gotten a call from Steve Joseph, the Commissioner of Health, who said that they were looking for someone to be assigned by CDC. And he said, are you interested? And I said, when does the bus leave? Yes. And so I went with Harold Jaffe. Harold and I flew up to New York, and we met with Steve Joseph and I believe Steve Schultz. We went to lunch, and they basically agreed that I'd be detailed New York City Department of Health for as a CDC assignee. Martha Rogers was my supervisor in the Epi branch. Mm-hmm. And I largely worked on, I reported to Polly Thomas, who's another great mentor, about how to move ideas through organizations. And Polly was the director of surveillance, and I was the head of, I guess, the research unit within surveillance. Then Polly went on leave, and I actually was the acting director of surveillance for about half a year while my period was there. But I largely worked on the completeness of AIDS case reporting, which I think we published in JAMA, and the spectrum of HIV disease that didn't meet the case definition, which mm-hmm. I think we published in AIDS. And so those are my major responsibilities, being involved in routine surveillance. But it was a very tumultuous time because...
what was going on in New York at that time? So we're talking, you were there in the late 80s, early 90s,
right,
before very much HIV treatment available.
Right. It was, I think AZT was monotherapy. I was also seeing patients at the Beth Israel Medical Center. And so it was the AZT monotherapy era where our patients were taking 2 pills every 4 hours and having to wake up for the 4 a.m. dose. And many of them responded, and it was a miracle for a while, but I guess we weren't aware it wasn't lasting long. They were getting resistant to monotherapy. And so that was a very difficult time clinically because, but we were trying our best, I remember at that point. And then at the health department, there was, quite a lot of activism about the HIV epidemic, and quite a lot of it directed at the health department. And so it was an interesting time. We used to have, I'll tell 3 quick anecdotes, and then I think we can move on. The first is we used to have a monthly surveillance report where the health department would report back to the community and to the press and to the clinicians who were taking care of patients how the AIDS epidemic was going. They'd been doing that apparently since the start. And then Isaac Weisjuice and I actually were assigned to take over that, and there was a lot of understandable anger, and why aren't people doing more, and we had to bear the we were the sort of frontline people giving those reports and trying our best to answer questions. The second was, of course, ACT UP was very important voice in bringing HIV care to the fore, and I had great respect for a lot of the people. I actually took care of clinically of some patients who were ACT UP members. Some of my friends were ACT UP members. So, I had great respect for what they were doing. But on the other hand, they were really angry at the federal government and the local government. And so they raided our offices once, and I remember that when New York City lowered the estimates of the number of HIV-infected patients, they did this campaign saying that the blood of hundreds of thousands of New Yorkers were on their hands, and there were these handprints of red paint, put all over the city. And then also at that point, it was the era of the 4 H's, where there was a lot of stigma of heroin users and homosexuals and hemophiliacs and Haitians, and caused terrible stigma in these populations. I remember that there's a very large Haitian community in Brooklyn. And I remember we were at the health department, and there was a big march. We could see out the window of the Brooklyn Bridge. They were coming towards the health department, and there were mounted police at the health department. And it was a very challenging time, because on one hand we were representing the federal and local government in our professional capacities, but of course, from a social justice point of view, could certainly identify with a lot of the people who were protesting was against us. And I really think that the mutual respect that was developed between public health professionals and the activist community over time was really instrumental in us hearing them and respecting their input. And as you know the story, yes, probably better than me best, it had an incredible positive influence on clinical trials and bringing HIV medicines to the fore. And so I still know some of these people to this day, and those were tumultuous times.
What were some of the things that you think either CDC or you as a federal assignee and other federal assignees in New York City Health Department and the health department, what were some things that you think worked, that made things better?
I think one of the themes that I saw both domestically and internationally, and something I really respect that CDC as an institution has always done, I don't know always well, but in my experience well, was to provide technical assistance and work with and for the local public health authorities. So when I was working in Zaire, we were reporting to the Ministry of Health. We weren't just parachuting in and being, U.S. government scientists, but we worked in collaboration with and for. I was assigned, Dr. Nzila and Dr. Ngali were my partners, and this famous lecturer is named at Croy, the opening lecturer after Dr. Nzila and Dr. Mann. There's the Mann and Ngali lecture. But we were counterparts, and I think when I was assigned to Zaire, it was very clear that we were there at the invitation of the government, and we had to regularly report to the government. I'll talk about that when we get to Retro C. So, we weren't just there in isolation. We were working for the Ministry of Health. And I think similarly, CDC's relationship to this, we had to be invited in by the New York City Health Department. Then I reported very clearly to Parley Thomas, who reported to Steve Schultz, So we were welcomed in, but with a very clear understanding that we were working for them and with them, not apart from them, not with our own agenda. And I think that's been one of the great, in my career, one of the great privileges to see how CDC does that and doesn't impose its will, but works very closely with local or international health authorities. So that's my answer.
With regard to surveillance, can you say a little bit more about that? Was there the beginning of electronic reporting at that time? Were you still having the telephone call and the forms? What was reporting in New York City consisting of at that time? For future viewers, I think people can't believe that there weren't always computers for these huge outbreaks.
Right. It was I have several memories of technology emerging during that time. One was that there was no email. And so every day, I remember going to lunch, the secretaries would take messages on those little pink slips, and I'd come back from lunch, and sometimes I'd have 20 or 30 phone calls to return. So I spent my mornings doing work, and my afternoons returning phone calls. I remember I think we registered for the Florence AIDS Conference, and it was the first time I ever saw a fax machine. And I remember, so they had just bought a fax machine. I didn't even know it existed. And I said, well, do we have to mail these by airmail to Italy? And they said, no, you just put it in this thing and it comes up in Italy. And I remember, really? And so it was a different era, and a lot more manual work. There certainly wasn't electronic lab reporting in those early years that I recall. My recollection, again, the New York City Health Department would be better to answer this than me, but my recollection was there were over 80 reporting hospitals plus private physicians, and different public health workers were assigned surveillance duties who would visit and get the case reports and record them onto the CDC forms.
Handwritten.
Yeah. I think so. Again,
Yeah.
if I'm on camera and I may be making a mistake.
Yeah, no, I think that's right.
There were no iPads to put it into, so
right.
it was brute force. Yeah.
Well, maybe let's move on to your time in Côte d'Ivoire as director of Projet Retro C, which was, I have 93 to 1997.
Correct.
So this was a pretty prized position to get as director of Projet Retro C, the HIV/AIDS field station in Côte d'Ivoire. You were Dr. Kevin DeCock's successor, as the project was initially set up in '88 and initially placing emphasis on studying HIV-2, a second retrovirus that was prevalent in West Africa. Can you describe the field station when you arrived, number of staff, colleagues, the relationship with the Ivoirian government? What was that like?
Well,
that had to have been a big move.
It was a big move, and that's when I made the transformation from, in the same way that I had transformed from a clinician, even though I still practiced AIDS medicine until a couple of years ago. I was a voluntary physician for my whole career, but I transitioned my primary occupation from a clinician to an epidemiologist. And then in Côte d'Ivoire, that's when I started transitioning from an epidemiologist to more of a manager of science, I guess, and moving into leadership roles, which I've been in since, and actually getting formal training in management. So, but I remember at one of the International AIDS conferences being interviewed for the position by Kevin himself, the great Kevin de Kock, whom I knew from EIS, but is really one of the leading scientists. He's a good friend, but respectfully, he's one of the leading HIV scientists in the world, and succeeding him, little old me, it was pretty big shoes to fill. And so I remember I flew to Abidjan, and when he was still there, and we spent 3 or 4 days him orienting me, and we went to the he had a little shack on the beach. We went and he gave me these life lessons of how to be a good director, and and then a couple of months later I moved there with I was married at the time. I'm still married, but I had gotten married, and my wife and I moved to Abidjan together. And I remember showing up the first day on the job, and I was a little more jovial in those days, and meeting Professor Kadia, who was the director of infectious diseases. And he was my boss and became my mentor there. And I remember he looked at me and said, "So you're the one who's going to replace Kevin de Kock?" I said, "Yeah, I'm going to do my best, Professor Kadia. I'll never be Kevin, but I'll try my hardest." And thus launched an incredible experience. Kevin had modeled the structure of Projet Retrocy after Projet Sida, and I'm sure he probably told that story. But it was again a partnership with the Ministry of Health and the Ivorian. There were many Ivorian physicians who Kevin had in leadership roles, and Institute of Tropical Medicine, and Peter Piot Peter Gees, who's now head of surveillance at the World Health at UNAIDS. It was the assignee from the Institute of Tropical Medicine in Antwerp. And Kevin also involved the London School, where he became faculty, and Alison Grant represented the London School. So it was this United Nations. My recollection, by the time I left, again, I don't have my data, but I think there were about 100 staff from 14 countries. And I remember we once did a survey, how many languages, there was something like 50, 60 languages that were spoken. It was, because there were people from all over West Africa, Benin, Togo, Ivory Coast, Burkina Faso, Uganda, Kabibi was from, just on and on. So it was an incredibly vibrant and interesting place. It was Francophone, where all business was conducted in French. And it was a very exciting that there were fleets of vehicles for, I think there were 10 or 12 vehicles. There were gardeners. It was built in the in a renovated section of the infectious diseases department of CHU de Trècheville, which was like Mamiemo, one of the larger, if not the largest public hospital in Abidjan. So it was quite formidable walking in there.
So by that time, what were some of the critical research and programmatic questions that you focused on, or that you and your colleagues focused on? How was that moving forward?
Right. The way the project was structured is we created sections, and so there was the support sections, the laboratory section, the section informatique, the data management section, and then 4 scientific sections that would actually do were doing the studies, and each had a major project. So there was mother-child, clinical, transmission, tuberculosis, and which was the major opportunistic illness, and sexually transmitted diseases. And so the major studies were, there was at that point, my recollection. So until '96, there was dual therapy in the United States, but antiretrovirals were just trickling in at that point. So it was still the pretreatment era, and the desire to do something about the epidemic was really to intervene as much as we could was really the driving force. And the first were the adaptation of the AZT regimen in 076. It had been shown to be successful, but that was a very prolonged therapy, and it had intravenous
for reduction of mother-to-child
transmission. And the ministry was very keen on trying to see whether or not we could come up with a quicker, low-cost regimen that could be implemented much more quickly. So those were the short-course AZT trials, which worked. And then the second series of studies was trying to lower morbidity and mortality using Bactrim prophylaxis in HIV tuberculosis patients, which was also published in The Lancet, and along with a French group who actually worked on both issues as well.
Now that one ended up having a huge impact in terms of implementing cotrimoxazole preventive therapy throughout Africa. Isn't that correct?
Well, I'm not on the programmatic side, but so I don't have any data. But I do think those results were picked up and disseminated. And
they were hugely impactful over the
Yeah, because it reduced morbidity and mortality. From my recollection was it had an impact on malaria and different infectious diseases.
Can you talk a little bit more about why cotrimoxazole, Bactrim, was identified as a key preventive strategy?
Now, Stefan Victor was the PI of the two trials.
Yeah.
Are you interviewing Stefan as well? Maybe.
Yeah.
Well, you can certainly talk to him. My recollection was that Alison Grant, who was working in the London schools, along with Gaston Chaumont for the Ministry of Health, had published the sort of spectrum of disease project. We did an in-depth laboratory investigation of the spectrum of HIV disease and looked to see, other than what people were getting hospitalized and dying from, and published that. And then I guess had the thought, which I think that our French counterparts also had, which is looking at the spectrum of disease, that Bactrim could have the potential for preventing morbidity and mortality, and it worked. And so that was.
And why TB patients? They were the early patients identified. They presented with higher CD4 counts, and so they were sort of like the canary. I
think TB was the most common opportunistic illness that we were seeing, and so the Côte d'Ivoire had a tremendous screening. You probably remember screening program for tuberculosis. They had 8 what were called CAT, Centre Antituberculeux, scattered throughout the country, 2 of which were in Abidjan, and they saw a large number of patients. In one of our other projects, we set up HIV screening in all 8 of them around the country, and so we sort of knew that these were HIV TB patients who were accessible and were fairly advanced in their disease. And so in pre-antiretroviral era, there was an opportunity, my recollection is, to provide some reduction and help to them.
That was also pretty amazing. Over time, we did a lot of work on trying to get HIV testing in TB clinics, but I think yours in Côte d'Ivoire was one of the early ones where they actually did it in a very large scale. Do you recall any of the issues that concern, I think, in terms of who's going to do the HIV testing, or how will that work in a TB clinic? Or
yeah, we worked with the director of the national program, is Dr. Koulibaly, Issa Malik, and he and I literally went around the country and visited with my wife and at that point our first baby in the back of a car, and he basically said he would teach me how to work in these environments. And so he was my mentor. And so we would travel to all far reaches. These were strategically positioned all over the country. So, 12, 14 hours in a car with a screaming child. And the first thing was to get local buy-in. So so we met with the local governors, the political representatives, the local physicians groups, the tuberculosis control people. But very importantly, we met with the local tribal leaders. And those were fascinating meetings where, these are very respected and powerful leaders of their communities. And Issa Malik taught me how to meet with them and how to, like, for example, in most cases, you couldn't address them directly. You would address their intermediary who would then translate what you were saying for them. It was, there were gifts that had to be given, small gifts, like laundry detergent. It was symbolic. It wasn't anything of more than a couple of pennies of value. But you had to show up with soap, actually. And who knew? But Issa Malik knew. And so the idea was to make sure that the local, both tribal and governmental authorities were supportive and saw this of value, because obviously this screening would allow people to, hopefully link to services that they wouldn't otherwise, and prevent their loved ones from getting HIV as well. So,
in so many countries, there was this fear of dual stigma, and that if you start testing for HIV in a TB clinic, word will get around you have AIDS if you have TB. And did you have to deal with that at that time?
My recollection, I wasn't on the front lines, but my recollection is that it was handled confidentially and respectfully, and again, Stefan would be the person to sort of recall more the day-to-day of this, but I don't recall any major controversies emerging. I think it was.
How was HIV/AIDS looked at in the Ivorian culture? Was it stigmatized in a major way, as it was in so many other countries in Eastern and Southern Africa?
I think it was because there was no treatment readily available at that point. It was largely quiet. I think people would, you'd hear someone died, or there were many, many funerals, and it was often unspoken what they died of, and so I think, yes, there was stigma associated with it, and people largely kept it to themselves and their families. It wasn't without treatment. Was there
a lot of issues around divorce or rejection of partners that were HIV positive?
I think you did hear both. Everywhere in the world you did hear stories like that.
Mm-hmm. But it doesn't sound like it was big and in the front.
It was very much in the press, yeah. I think that's why the miracle of PEPFAR was such a welcome relief. I think people became increasingly aware, especially since the government was so proactive, and we were publishing our results, and the media, there was a very vibrant media that Kevin and then myself and others were, especially our Ivorian counterparts, were talking to. So I think the depth and breadth of the problem was emerging. Every month I had to go see the Director General, so the person who reported to the Ministry of Health. So I'd go up to the Ministry of Health and take this private elevator to the top and have to report everything we were doing. And then he would bring that to the minister, and so it was very much a public health issue, and that people were increasingly aware of, and I think hopefully laid the foundation for the receptivity to the PEPFAR program. I mean, the opportunity, again, I as you know, I didn't work in the PEPFAR program, but the opportunity to treat people is what has been the game changer for the epidemic everywhere, and I think certainly Ivory Coast, if you talk to people who have been involved in the program, was well positioned to take advantage of that, because there was HIV screening, and there was good access to care in some sectors.
So you were doing randomized controlled trials, short course AZT, cotrimoxazole. Did the Ivorians buy into the randomized control approach? Were they comfortable with placebo? Was there any data safety monitoring or group representing the Ivorians? How did that go for you?
Yeah, I mean, we definitely, there was a Ministry of Health Institutional Review Board that monitored the trials. There was, my recollection is that the Ivorians wanted things that could help them. I think that was, help their people. I think that was their primary motivation to, because there were no ARVs available widely, that to develop interventions that could be cost effective, and at that point there was no PEPFARs, to things they could afford and implement. I think that was their desire, and to know that they worked in their context. That was a very, very important point, that they wanted to, their impression as scientists, there's so many variables and different sets of issues in every different environment. They wanted to know that these things could be shown to be effective in Africa and in their own country. And so they were very supportive and encouraging to try to do things that we could do quickly and prove to be effective. And that was true for AZT as well as Bactrim.
What about the placebo control? The issue of not treating some of the moms with the shorter course AZT,
right? It was
076 trial. Was there concern, you know, over the years, there have been concerns over placebo-controlled trials in many different settings. What was it like then? We're still sort of early in the AIDS epidemic, but there is information that AZT short course can work. So how did that go with the Ivorian government?
Again, my recollection is their position was that it would have been 076 required, my recollection is pre and post oral and then intravenous therapy as well with AZT. They felt in that context that it was not reproducible. At that period of time, they couldn't afford it, they didn't have the facilities for it, and they couldn't roll it, they couldn't scale it. And so they wanted to come up with a short course. There were many scientific meetings about it. Most of the transmission occurred, you know, around the time of labor and delivery, according to the scientific information that was available. And they thought we could capture a lot of it by administering an oral drug for a very short period of time, which turned out to be true. Mm-hmm. There was the controversies was largely not within Côte d'Ivoire. It largely came from outside of Côte d'Ivoire, and there was quite a lot of discussion about it in the international media.
About what aspect of it?
About the choice to use placebos.
Uh-huh. And
you know, I remember CDC had a post hoc consultation with a number of ethicists, and were you at that meeting? It was very interesting.
I'm aware of it.
They brought in leading ethicists from that, and the conclusion was that my recollection, the conclusion was that ethically it was justifiable, but CDC could have been more public about it early on. No one was trying to hide things or doing things surreptitiously. It was the honest feeling of not only the Ivorian scientists, but many African scientists published that at that point in the pre-PEPFAR era, there was an emergency to come up with randomized clinical trial data of things that could work for their people in that context.
And the current strategy was no treatment, so that the placebo wasn't going against what was standard approach.
Right, standard of care was just, you know, documenting the transmission rates.
Right.
I mean, it was nothing, and so.
So that took some guts to kind of to do those.
Yeah, and I think the valuable lesson that I think institutionally was when there are things that are, you know, controversial, to bring them out for public discussion and for scientific discussion. Which I think had been done in the public health world, but not in the mass media world, and so it was certainly a very important experience in our careers.
You had a family. You've already said that one of your children was screaming throughout the rides around
Poor
Côte
thing,
d'Ivoire.
they were long rides.
Can you tell us a little bit about that? Is that where you actually had your children? Were they born in Côte d'Ivoire?
So I met my wife in the New York City Health Department. She was an epidemiologist there, and then she went back and got her PhD when we were in New York. And then her father was a travel agent that led safaris to Africa, so she also spoke French, and she also had a love for sub-Saharan Africa, and so we went together. And there's this famous story family story where we went to our check-in physical at the embassy, and the nurse, they drew our blood, they did physical exams, because you're also part of a walking donor bank for the U.S. Embassy population, so they had to blood type you, and the nurse came out and said, well, you're both healthy, and by the way, Mrs. Greenberg, congratulations. And we had been to Abidjan for a week, and I said, what? She said, well, you're going to have a baby. And I think I fainted, is the story. And so Michelle had her first pregnancy. We had our first pregnancy in Ivory Coast, our second pregnancy as well. Our two daughters, they actually medevac the husband, the mothers 6 weeks before and 6 weeks after, back to the U.S. for delivery, and the husbands 3 weeks before and 3 weeks after. So both our daughters were born in the Bronx. And so by the time we left Abidjan, we had a 3 and a 1 year old there. Michelle likes to tell the story. I was so happy to become a new father that I announced to the Ivorians and to the Projet Retro C staff that if I had a healthy, alive child, that I would throw a big party for everyone. So they held us to it, and we had two of the most incredibly meaningful nights of our lives. We have it on video with African dancers, and I remember we had like 6 goats, and they brought the whole goats, and they were with foil on the legs, and they carved the goats up, and 50 chickens, and had 100+ people at our home.
Oh my goodness!
And we did 2 of these, with speeches and great merrymaking, and thankful for healthy children. And then our 3rd child was born later on when we were Boston, our son. But those were some intense times for child rearing.
How did it go with your work demands and family demands?
Well, the spouses of those, we were working very long hours. I mean, the obligation to, run a project of this magnitude, continue to be productive scientifically, and trying to have a personal life was all blended up. We socialized a lot with each other. Those remain some of our closest friends. The other is John Nkengasong, who's now head of the African CDC. That's a good story when we hired John, but if we have some time. But we were working really hard. Michelle likes to tell the story that Peter and I were talking to our wives once and said, we're really busy now, but in April things are going to calm down. It was like January or something. We really think once we get to April it'll calm down. And so I think the joke is 30 years later, they're still waiting for April, So these are, these are not positions that require a small amount of work, and I think require, a good amount of family support. And I think Kevin once made a speech where he said, you need 3 things to succeed as a Projet Retro C director. He said, let's see if I can remember, a big heart, a good mind, and a strong spinal column. I'm glad I was young when I did it, because it took quite a lot of long hours, and trying to be a good father and a good husband at the same time. You have so much professional responsibility. On the other hand, I grew up. I mean, it really was a life-changing experience for me. I remember waking up one day, always feeling, I was 35 when I started, and always feeling like I was still an adolescent. But one day I was sitting there looking at my wife and 2 kids, and 100 people looking at me, and I said, I think I just grew up. And indeed, when I left Ivory Coast, there was a ceremony at the Ministry of Health where the minister said, Alan, tu as fait 2 enfants, you've made 2 children here, you've become an Ivorian. He said, now you've become a man, So, there was this notion that it was a very maturational experience, both as a scientist and as a human being.
What were some of the most pressing management issues you had to deal with?
Well, management always comes down to fiscal and HR, right? So, number one, compared to PEPFAR, it wasn't huge amounts of money, but it was still millions of dollars, and trying to absorb the weight of being responsible for that much taxpayer money. At that point, I don't have $1 million. It was a huge amount of money, and trying to make sure we were fiscally prudent and responsible, and we knew where every dollar was, which I think we largely did, and absorbing the responsibility, which I have to this day, of managing funds, government funds well. I think that's part of it. The other big challenge is HR. When you're running, it was a bit of a Tower of Babel. There were people from so many different cultures, and trying to trying to create an environment of respect, and where diversity is celebrated, and where people from different cultures feel comfortable and feel like they're valued. I think that learning to be a manager, not only in the fiscal side, but really, and also trying to pick people who fit. That's been, anyone who works with me knows I have a very quick mantra, which is hire smart and nice. Keep it simple. Try to not only hire the smartest person you can, but people who you want to see at work every day. And so there were a lot of, for lack of a better word, smart, convivial people who worked in the project that Kevin had hired, and then I try to continue that tradition. And so I think, but all those things are easier said than done. You have to take the time to know Excel and know where the dollars are, and watch over that yourself, and have a hand in the hiring of people so that you can create a certain kind of and leadership. I think learning to give big speeches, and which I had never done in my life, and be more charismatic than would necessarily come naturally. And learning to be a public figure, learning to speak to the media, and learning to deal with controversy, and also being in assignee, where you're so, again, at that point email was there, and but communications weren't quite, there was no face chat, it still wasn't the same, and having the responsibility of a lot of U.S. government resources in a far-flung part of the world. Now there's many people at CDC who've had that privilege through the PMI and through PEPFAR, but there was just the field station in Thailand, and the field station in Kinshasa, and the field station in Cote d'Ivoire. There was the yellow fever. There was Lassa fever that Joe McCormick had in West Africa, but there weren't dozens. There was a handful. And if you
Who was your quote-unquote control officer in Atlanta? Who did you look to for support?
Tim Dodero. So Tim was another amazing. I've been blessed, to have worked with all these great figures. Tim was the head of global HIV branch. I think it was called the International AIDS branch, and was my direct supervisor. And so I had to keep him and his, Phil Nyberg. He was the deputy. I had to keep them closely informed. So that's another challenge of the job, having a lot of bosses. So I reported on the Ivorian side to the Director General of the Ministry of Health and to Professor Caddio, and they definitely, as you say, their engagement in the design of all these trials and handling the media, they were not passive partners. They were very much engaged, and both scientifically and policy-wise. And then I had my boss at the embassy, because I was head of agency, so I reported to the U.S. ambassador. So we had to keep, the U.S. Embassy. I'm sure all the PEPFAR people have gone through this, but at this point it was all new to me, and trying to make sure the U.S. Embassy, which was supporting us, supporting our homes and supporting our families, were quite aware of what we were doing and could report back to, I guess, State Department about what we were up to, and then reporting to CDC. Because after all, we were CDC assignees, and reporting to DHAP, and they very much wanted to know what was going on. So, long, science, management, money, hiring, leadership, it's all challenging. And those of us who were privileged to be given those opportunities, I think we all take it seriously, and nothing's perfect, but you try to do the best you can and contribute as much as you can for as long as you can.
The political landscape of Cote d'Ivoire has changed over the decades. I mean, there have been a lot of periods of fighting and danger in different parts. You described driving pretty much throughout the country with Dr. Coulibaly, Malek, and what was the political situation during the years you were there? Was it fairly calm? Was there a good relationship north and south?
Yeah, my recollection is, there were the founding days of Houphouët, the father and first president of the country, and the government changed while we were there. And I remember the first transition of, I have to look this all up, Beth, so I apologize, but my recollection is that there was concern about the handover of power, but that it went, I remember we were confined to our houses, I remember that, for a couple of days by the embassy, but I think things went relatively peacefully. I left Cote d'Ivoire, and then, after I got my master's in public health, I was the Epi branch chief for HIV for many years, and I went back to Ivory Coast for a meeting, actually to open a vaccine research center, was my recollection. And we were in the Hotel Ivoire staying, and I got a call at 3 in the morning from Marie Laga, who was there, saying, "Look out your window." And I said, "It's 3 in the morning," and you could hear and see gunfire, and that was, I think, the first outbreak of what became, the more widespread conflict in the country. And some of my colleagues lived through a lot more. We then left in '97, and I don't have the whole history in my head, but we were not there during the crisis, but many of our friends were, and certainly many of our Ivorian colleagues were.
Did you have any concerns about your safety and the safety of your family then while you were there?
Well, there was always health concerns. We were loved Ivorian food, and so we were out eating in local restaurants very often and had quite a number of cases of food-related enteric illnesses. I was hospitalized with cerebral malaria during one of my latter years.
Were you taking malaria prophylaxis?
I was, but...
And your family as well?
Yeah, but, largely we were in air-conditioned settings, and so you could get away in Abidjan with personal protection because, the mosquitoes were largely biting in the evenings, and so...
So that you would go through periods where you would not take malaria prophylaxis?
Early on, till I got malaria.
And so then you got you were severely ill?
I was hospitalized, yeah. So I think there was concerns about... And what happened was I was traveling on these tuberculosis. I wasn't always the best patient. You'd think I would have been, but...
I'm just hoping you didn't call your mother when you were hospitalized.
No, actually, my wife was attending her cousin's wedding in Italy, and I wasn't feeling well, so I called Pat Whitaker, who's the head of the data management section. He came over, he said, "I think we better get you to the hospital." So I went to Pizam, which was the hospital, and I said, "Oh, I'll be all right." And they said, no, you won't. And so I actually don't remember being in a hospital, but I remember Angie, who was Peter Geis's wife, was a nurse. And apparently she came and was with me for a couple of days while I was out.
Wow.
And when I woke up, she was sitting there in a chair smiling, and she said, "I'm a nurse, remember?" She goes, "Your wife wasn't here, so I took over," And I was quite ill. So there were, in terms of physical safety, we lived in U.S. Embassy housing, so we had guards and have very secure facilities. There were we had 100 people in the project, so you did hear of issues. There were house break-ins, there were some street crime, and so, dealing with staff, trying to support staff who'd been through difficult episodes. Some of whom, were able to handle it well, and some of whom who were affected. So there was definitely physical. Was
there an anti-American feeling, or at that time, not really?
No, I don't recall being stigmatized as an American. There was, because it was French West Africa, there weren't that many Americans who would be there and work there. There was the embassy, but it was largely a French-dominated. It was a French colony, and then they had their independence, I think, in 1960. So my recollection is, when they thought of the West, they thought more towards Europe than they thought towards the United States. So I don't remember any, I could be wrong, and my colleagues who are watching this could be correcting me, but I don't remember any anti-Americanism being an issue. I think we were viewed as, trying to help.
Mm. So before we move towards conclusions, can you just tell us in a few words about your career since then? You've had a long and a very full career on HIV/AIDS since then. Do you want to just give us a few words about what that's been like?
Sure, I'll do it in a quick paragraph, and because I know time is short. So after I left Mabijahn, I remember going to Helene Gale, who was the center director, and I said, Helene, I had this incredible experience being a leader of a project, but I'm at a career crossroads and I need your help. I said, either I'm going to be a scientist at CDC or a manager of science, and if I'm going to be a manager, then I really think I'd benefit from training. And so she supported that, and so I went to the Harvard School of Public Health to work with John, John Mann, and actually didn't, as I said before, didn't wind up doing that because he left and then passed away, unfortunately. But I was in the health policy and management track, and I took as many courses on organizational strategy and structure as I possibly could have. So I really try to, sort of cross-train and understand a little more. A lot of physicians manage intuitively and from their experiences in the clinical world or at CDC but I actually wanted, and it really helped me. I learned how to do strategic planning, and Harvard's famous for their case studies, and so many issues that have come to me subsequently, I said, I already studied about that. It gives you some basis that you're not managing intuitively or based on your own experience, but managing in ways that you've learned about. And so that was a life-changing, career-changing experience for me. So, and then halfway through that time in Boston, Kevin DeCock became the division director of DHAP, and once again reached out to me and said, I'd like you to be the chief of the AIDS epidemiology branch. And I said, but I'm living in Boston. And he said, well, commute. And so I then was the chief of the HIV epidemiology branch from 1998 to 2005 when I retired. And that, we won't have time today, but that was, an incredibly rich experience because, we worked in, I think dozens of states and 10 countries and around the world. And I had the privilege of, supporting some of the most amazing scientists who to this day have gone on to do wonderful things. And so that was a very prideful. And then I retired from the Commission Corps in 2005 at my 20-year anniversary, and I was recruited back to my alma mater by the then Dean Ruth Katz, who was, I think, on the CDC advisory board or Emory. She has an Atlanta connection, and she knew I was retirement eligible, and she came down and got me with the tagline, how would you like to move back to your alma mater and help build a school of public health in the nation's capital? And I remember thinking that, my wife said, that sounds like you. And so we moved 3 generations of our family from Atlanta to Washington, and for the last, I'm now starting my 13th year. I'm chair of the Department of Epidemiology and Biostatistics. I have 3 jobs, basically. I'm academic chair of a department, which is related to but very different than being a branch chief at CDC, in that at CDC you have, some line authority. Of course, you report to the division director, but this is, the tables have turned. I report to the faculty, and so it's very interesting managing an environment where you're more a managing partner than you are, a supervisor. I certainly don't supervise the faculty, and of course we had the wonder of being, around young scholars in their 20s and doctoral students and young faculty, and the privilege of, like, mentoring AS officers, mentoring the next generation of epidemiologists. And that's been, in our school, we don't have time today, but it's grown dramatically, and we have our own building now and an endowment and a great dean, and it's really been a privilege to do that. My second job is the AIDS epidemic in Washington, D.C. was considerable, and the idea, and despite having such a severe epidemic, there had never been what's called a Center for AIDS Research. The NIH sponsors CFARs, or Centers for AIDS Research, in the United States. And GW, the university where I work, wasn't large enough and didn't have enough grant money to qualify. So I always say, other than marrying my wife, the only good idea I've ever had in my life was, I thought if we could get everybody in the city to work together, that we would qualify and have not a university-based CFAR, but a city-based CFAR, citywide CFAR. And so we
inspired.
We started an AIDS Institute, and we were then funded by the NIH for a developmental CFAR. Now, since 2015, we're a full CFAR. We now have 275 faculty members from 8 institutions: GW, Georgetown, Howard, and American universities, Children's National Medical Center, the VA, Medical Center in D.C., the very well-known Whitman Walker Health Clinic, which is a very large community-based clinic, and the D.C. Department of Health.
And the mandate of that CFAR
our mission is to support HIV research that will contribute to ending the AIDS epidemic in Washington, D.C. and beyond, in partnership with community and government. And if we had more time, I could talk about what that means, but we work very closely with the community and government. Indeed, AIDS cases have fallen from, I think there were 1,350-ish in 2007, and we're now, I think, in the low 300s. And so there's been a 70+% reduction in the number of HIV cases. And how that was done is a whole nother story, but it's really been a privilege to work with the government and the local government and the NIH and the community to help contribute to that change. Of course, led by the health department. They deservedly deserve most of the credit for coordinating the response. And then my third job is as an HIV researcher. So we're a member of the HIV Prevention Trials Network. We have a clinical research site where we do interventional trials to prevent HIV in high-risk populations. Intramuscular PrEP, for example, being one of the studies we do now. We have a large cohort study of consenting HIV patients from participants from 14 soon to be 15 HIV clinics, where we do a monthly electronic medical merge, which is an IT challenge. But we figured out how to do it, and we're starting to characterize this population very well and trying to bring interventions to the population, which is very exciting, improve clinical care, and other studies as well.
Well, you've certainly had an amazing career. Before we conclude, any general thoughts on your work for CDC and in the various settings and the various topics you covered? We've discussed it some. Any further thoughts on your work with CDC?
Sure. First, it was an absolute privilege and remains a privilege to work with the CDC. It's an incredible organization filled with, I think now that I'm in academia in a much smaller environment, you walk around these hallways and there's not just dozens of epidemiologists, but thousands of epidemiologists. I don't think when I was here I quite realized how unique. I realized it was great, but I didn't realize how unique it was. I mean, there's probably nowhere in the world that has such a confluence of public health experts on such a wide range of disease. There couldn't be. And so I think that's that. And then, as you know, Bess, I've had the privilege to serve on advisory boards for CDC, the advisory committee to the director, and chair that for Dr. Frieden. And that was an incredible experience when I continue to be wowed by CDC's response to Ebola. I mean, it's just an amazing place. And I think that's the first, is just how respectful and in awe I am of, and how awed that I had these opportunities in one lifetime. Second thing is mentorship. As I've tried to explain today, I've had the benefit of amazing mentors. In malaria, Ken Campbell, Joel Bremen, Phuc Nguyen Din, and the Zaire days, Jim Curran, Peter Piot. These are giants. Kevin DeCock, Robin Ryder, John Mann, Phuc Nguyen Din in malaria, and then Polly Thomas. And they all took way extra time, probably away from their families, to review my manuscripts, to review protocols, to help Helene, who had the vision to send me for management training, which was so transformational in my career. I think that was a second lesson learned. And what I've tried to do, I actually wrote an article, editorial in AJPH about this month, is do that myself and mentor as many people as I could while I could. And I am so proud of some of the people. I mean, you can't take, success has a lot of mothers, so you're not solely responsible. But at one point or another, I hired and gave some input into amazing people who've gone on, Stefan Victor, who was head of hepatitis C for the World Health Organization, Dr. Ekpini in Abidjan, who was mother-child for UNAIDS, for UNICEF, Peter Gees, who
You have so many wonderful things to say about CDC. Is there anything over the years that you feel that CDC could have done better?
Huh. Well, I don't know the whole of CDC, so I just know.
In your experience, yeah.
I don't want to be a Pollyanna, but CDC did a lot with a little amount of fun. When I think of the budget of DHAP, I don't know what it is, but it was hundreds of millions, not billions. The incredible things they've done with those resources, and internationally, CDC's role in the PEPFAR program, which I wasn't privileged enough to have the opportunity to work in directly, but so many of my close colleagues have, and they put up those slides with the lives saved, Debbie Burks. I mean, it's incredible. I mean, the 35,000-foot answer to that is I'd have to think about it, because nothing's perfect. But all in all, when I think of CDC, it's sort of an organization shining on a hill. It's not. Well, we got to get rid of that one. It's the leader in public health and prevention. And when I was fortunate enough to serve on the committee and learned about the advisory committee, learned about the breadth of what goes on here. I mean, I was so busy doing what I was doing. Even now I work so hard, I don't even often know what's going on the floor below me or above me, and I should, but then I couldn't do all the things I do. And so, but when I served on that committee, you hear about, seat belts, and you hear about, violence prevention, and you hear about immunizations, and you hear about TB, and you hear about STD control and surveillance and responsiveness, and it's incredible. And there are plenty of other things to criticize. CDC is doing pretty well, I think.
Well, it's been a real privilege talking to you.
Thank you, Bess. It's been a great honor to have this opportunity to share the first half of my life story.
Thank you.